सर उसमें वीडियो इफेक्ट्स में स्टूडियो इफेक्ट्स आएगा सर बैकग्राउंड में। सर यू आर ऑन म्यूट सर। सर आप म्यूटेड है अभी भी।
हाँ, ये मैंने चेंज किया पर हुआ नहीं है वाला, फिर वो सेव नहीं हुआ शायद।
उस पे जाइए, वीडियो पे, वीडियो सेटिंग्स,
वीडियो सेटिंग्स
आप क्लिक कीजिए।
वीडियो सेटिंग इसमें है कहाँ पर?
वो जहाँ पे म्यूट आप करते हैं ना, म्यूट के आगे वीडियो होगा,
स्टार्ट वीडियो जो है। हाँ,
स्टार्ट वीडियो, उसी पे आप एरो पे क्लिक कीजिए।
एरो पे, अच्छा ठीक है। हाँ जी, हाँ हाँ, वीडियो सेटिंग है।
अब इसके आप इसमें आइए, बैकग्राउंड एंड इफेक्ट।
बैकग्राउंड इफेक्ट, ठीक है।
इसमें
इसमें
आप
दूसरा
इसमें आ जाइए, स्टूडियो इफेक्ट, सबसे नीचे राइट हैंड साइड पे देखिए,
स्टूडियो इफेक्ट। हाँ,
इस पे क्लिक
हाँ,
कीजिए। इसमें लिप कलर आ रहा है, उसको फर्स्ट वाला चूज कर दीजिए जिसमें क्रॉस बना है।
जिसमें क्रॉस बना है, ठीक है। हाँ,
अब देखिए
हाँ ठीक है, ठीक है, ये कर लिया। इसमें सेव भी करना है, ऐसे ही हो जाएगा, ऐसे ही हो गया ना?
इस तरह इसको क्लोज कर दीजिए, हो गया।
हाँ जी, ठीक है, ठीक है,
ठीक
थैंक
है
यू,
सर, ओके सर, ओके सर।
थैंक यू।
Sir, once my granddaughter was chatting with someone and she put the setting to the red color lips.
अच्छा।
And without knowing, I joined the room
जी।
and it was absolutely red color, very red. And I don't know how to do it. I was supposed to make a presentation. And it went on and on. And I could not, man, okay, no problem, I'll do it like this.
रवि शुरू कर दीजिए।
Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and allied health professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in basic sciences and applied clinical disciplines. In the virtual meeting held on 13 December 2022, more than 200 directors, deans, principals, CEOs, faculty members of the medical colleges and medical institutes decided unanimously that there is a need for the NAMS National Virtual Graduated Medical CME, Navigate Medico CME program for PG students, MD, MS, DNB, MDS. Accordingly, the Navigate Medico CME program was launched on 22 January 2023 by the NAMS President, Professor Dr. S.K. Sareen. Each online session is of 2 hours covering practical aspects as per the needs of the PG students in the identified theme areas. Thank you for your kind support.
Good evening, one and all. I welcome you all to today's Navigate Medico CME program. Now, I'd like to invite Professor Umesh Kapil sir, the Secretary of the National Academy of Medical Sciences, to provide his welcome address.
Good evening and namaskar to all. First of all, my thanks to all the participants who have joined in good number. My thanks to welcome to Professor Rakesh Chadha sir, who has been very kind and he has been very helpful to the National Academy of Medical Sciences. He has been organized a team of a series of lectures on psychiatric. This has been very useful. There are about, I can see, there are about 250 scientists who have joined online on YouTube. This is simultaneously being telecasted on YouTube. Also, what we have is all the Navigate lectures. We are putting it up on NAM's website, and this becomes a virtual library for all time to come. So anyone who is interested, he can see the all the presentations on the NAM's website. I must say that this is a humble effort of National Academy of Medical Sciences, and we are trying to make it the gradual success we want to achieve. It will be successful over a period of time. And what we have done that we'll have themes on which a series of lectures would be undertaken. Like we had a theme on diabetes and its complications taken up by Dr. Mohan from Diabetes Center, Chennai. So it's a very successful program. And I sincerely feel that we'll continue with this program. More and more people will join. They'll get benefited with this Navigate program. Once again, my most heartfelt gratitude to Dr. Rakesh Chadha sir, who very kindly agreed to help National Academy of Medical Sciences for organizing this series of lectures in the field of psychiatry. He is an outstanding scientist. If you ask me the number of publications, he has more than 300. He is the president-elect of World's Association of Social Psychiatry 2022 to 2025. And he is an outstanding. We are privileged to have him. And AIMS is always remain grateful to Dr. Chadha for his contribution. He's a very quiet and silent person, but we all admire him for his humility and extraordinary grasp of the subject of psychiatry. Thank you very much. I again welcome all of you and all the parts. Thank you very much. Over to you, Preeti, for introduction of Dr. Chadha, please.
Thank you, sir. It's an honor and a privilege to introduce the speaker for today's session, who is also the chief coordinator for the psychiatry team of the CME sessions in NAMS, Professor Rakesh Kumar Chadha, sir, who is the professor and head in the Department of Psychiatry and also the chief of the National Drug Dependence Treatment Center at AIMS, New Delhi. Sir is also the president-elect of World Association of Social Psychiatry for the year 2022 to 2025. He is a fellow of the Royal College of Psychiatrists of UK. He is also an international distinguished fellow of American Psychiatric Association. He is a honorary fellow of World Association for Social Psychiatry. He is a fellow of the National Academy of Medical Sciences of India, associate editor of British Journal of Psychiatry, handling editor of British Journal of Psychiatry International, and he is a recipient of 14 national awards in psychiatry, and he has more than 300 publications to his credit, including 12 books and monographs. Now, I would like to invite Professor Rakesh Kumar Chadha, sir, for the talk. Over to you, sir.
Thank you, Dr. Preeti, Dr. Kapil, and Dr. Sareen, Dr. Sood. Especially, I would like to thank the National Academy of Medical Sciences for inviting me for this program and for giving opportunity to the discipline of psychiatry to have a series of lectures on psychiatry. And today we will be discussing on forensic assessment in psychiatry. Okay. So the learning objectives for today's presentation would be the attendees would be familiar with the steps of forensic psychiatry assessment, how to differentiate between malingering and true mental illness, how to assess fitness to stand trial, and how to assess for testamentary capacity. When we talk about forensic psychiatry, this is something which is which has more practical implications, and during the post-graduation, one does not get a first-hand experience of forensic psychiatry assessment, because most of forensic psychiatry deals with the relation between law and psychiatry, and how to prepare medical reports, how to present in the court, how to respond to the queries of court. So I'll be discussing about some of these issues, and along with some live cases which I had dealt at different parts of time in my career. So some of the common requests which one receives, which a psychiatrist receives for forensic assessment, these can come from the courts or can come from the sometimes the employers. And these basically come in two categories. One is the related to the civil cases, which includes guardianship, testamentary capacity, divorce on ground of mental illness, child custody, and fitness for job. Fitness for job, generally, this request would come from the employers. And amongst the criminal group, the areas could be fitness to stand the trial of law, or fitness to plead, as it's called in the Western settings. In India, we call it as a fitness to stand the trial of law, and criminal responsibility. This is an example of letters which one gets from the court. Letter would generally be addressed to the head of the institution, and this would say, for example, this example is accused so and so is being produced by the superintendent jail at your hospital. You are requested to constitute a board to examine him and to determine his mental status and submit the details. It may also be examined whether he is in a position to understand the proceedings of this case or not, and the report we submitted on or before. There's usually some kind of deadline may be given, and given under my hand and seal of this court on this day of the specific date, signed by the court. Some common requests which one may get for forensic assessment. This is in form of statement. For example, for criminal cases, the statements questions could be whether the accused is suffering from a mental disorder, whether the accused is of unsound mind, whether he or she can understand the proceedings of the court, whether accused is fit to stand trial. Amongst the civil cases, the request could say to examine whether the person is capable of taking care of his person and manage his property, whether marriage can be declared null and void on ground of mental illness, whether the person is fit to continue in the job, whether a parent is fit to be given custody of the child, whether the person is competent to declare a will. That's a testamentary capacity. And the request may say that person is to be examined by a panel of psychiatrists. So these are the common requests which we may receive from the courts. Now, in forensic assessment, there are a number of ethical issues involved. First and foremost is the informed consent. If it's an order from the court or direction from the court, there is no question of informed consent. But if a request is coming from employer, so there we can't give a report or we can't examine the person without a consent from the concerned person who is to be examined. So if a request is coming from an employer, we should send, if it's not accompanied by a consent from the person to be examined, we can request, we can send an intimation to the employer that you send a consent from the person concerned. Then is a confidentiality, what all information is to be disclosed to the court. Now here the thing is that information, because in the doctor-patient relationship, the patient or the person who is examined may divulge a lot of information. So here the information which is relevant to the questions being asked by the court, only that much information should be disclosed, and not the other information. And the person, when the person who is examined, he or she also has to be told that the information what he or she is telling that can go against his or her case in the court. So the person should be aware of that. Though he or she is aware, but it's a responsibility of the psychiatrist to also caution the person. Then if the person is suffering from a mental disorder, then the treatment should always be offered. And the court also should be informed this person is having some mental illness, or this is a kind of mental illness, and this is a kind of treatment which is to be provided to the person. Now, before I go into further details, I will discuss some of the basic concepts in forensic psychiatry. Because these are unique to forensic psychiatry. They are not generally discussed in the general psychiatry. This would include mental illness, insanity, unsoundness of mind, crime, code of criminal procedure. This is specific to Indian courts. Concepts of criminal responsibility and concept of partial responsibility. In legal parlance, a term insanity and unsoundness of mind, these are frequently discussed. Whereas in psychiatry, we don't discuss the term unsoundness of mind, and insanity might have been discussed long back, that is centuries ago, that so and so has gone insane. Or sometimes in the English language, this term may be used in a general language. Now, insanity and unsoundness, these two are the legal terms, whereas mental illness is a medical term which we use in psychiatry. Insanity can be equated to any psychiatric illness, usually a psychotic one. Now, a person may be a fit person for confinement in a mental hospital or hospitalization, but this alone is not sufficient to permit him to enjoy exemption from punishment. So just having mental illness does not mean that you get exempted from the punishment as prescribed by the law. Now, unsoundness of mind means a state of mind in which person is incapable of knowing that he or she is doing any wrong or anything contrary to the law. So these two terms are frequently used, and when one goes to the court, the judge would ask whether this person is of sound mind or he has unsoundness of mind. And these are the questions often also asked in from the court in the letters which we get from the court. Now, another thing is, in law, every person is presumed to be sane and accountable for his or her act, unless the contrary is proved. Unless the contrary means unless the unsoundness of mind or insanity or mental illness is proved. And burden to prove insanity is upon the accused. Now, Section 84 of Indian Penal Code, which refers to insanity and unsoundness of mind or the criminal responsibility, it says that nothing is an offense which is done by a person who, at the time of doing it, by reason of unsoundness of mind, is incapable of knowing the nature of the act, or that he is doing what is either wrong or contrary to the law. So this definition has taken from the McNaughton's rule. Now, legal insanity means that at the time of commission of the crime, commission of the act, the person should be suffering from mental illness and also have loss of reasoning power. So just presence of mental illness does not mean the person would be exempted from the punishment. It has to be that person did not have the reasoning power at that time. Now, this includes inability to make judgment and to know consequences of the act. So reasoning power includes inability to make judgment and to know the consequences of act. So person is incapable of knowing nature of the act, or what he was doing is wrong or was wrong and was contrary to the law. So all these things, they should be fulfilled before a person can be considered insane as per the, or say, hey, mental or the unsound mind as per the law. Now, what is crime? No, just commission of act does not mean that this will fulfill the criteria for the crime. So crime has two components. One is the actus reus and other is a mens rea. And crime is an act which is declared by the law of land to be an offense at a particular time. It's a behavior which is in the violation of law and is punishable. Actus reus means that it's a guilty act against the law. So this is basically on the physical act physical component of the crime, and the mens rea is that evil intent or the guilty mind. That mind is guilty or evil intent. Intent was there to harm the person. So the action was accompanied by a guilty intent or culpable state of mind or evil intent, and the knowledge of the consequences. Now, both these elements must be present before an accused can be said to have committed the crime. Now, we have a code of criminal procedure which is described in the under section 328 to 339 of Code of Criminal Procedure of Indian Penal Code of it's of 1973. When an accused is lunatic, so see this still the term because in 1973 the Mental Health Act had not come, so that's why the term lunatic was used. The court still may use the term. So when accused is a lunatic and is consequently incapable of making a defense, the magistrate inquires in the fact of unsoundness of mind, including examination by a medical officer. If magistrate is satisfied that he is of unsound mind and thus incapable of making a defense, the proceedings of case may be postponed till the person gets better, gets competent to understand the court procedures, and then he or she can be tried. Now here, if a mental illness has been identified, the person, it's not that person would be released, person would be kept in a safe custody and or be released pending investigation or the trial if bail can be taken. So this procedure if can be fulfilled, otherwise person would be sent to a psychiatric hospital and treatment would be provided there, would be sent for treatment. And trial can resume only when the accused ceases to be of unsound mind. This criminal responsibility of McNaughton rules we have just discussed. Now here I would like to add that insanity defense is usually used in cases of murder, in charges of murder to escape capital punishment. Because otherwise also if insanity defense is proved that this person was insane at the time of committing the crime, person would not be released, person would be sent to mental hospital. So the purpose of the person can escape capital punishment, but he can't be released in the community. The person would be sent. So that's why it's a last defense which is generally used by the criminals. Another thing, caution is that unsoundness of mind should have existed at the time of committing the offense. An unsoundness of mind which has got afterwards, that's not a defense, but it can affect the trial because person may develop mental illness later, and becomes unfit to stand trial, unfit to stand trial. So then the person trial can be delayed, or person can escape the capital punishment. Now, when we have to assess a subject for criminal responsibility, there are certain steps to be followed. Now, these steps are generally of first is that we have to take detailed clinical history, that's a general psychiatric history, including personal, family, past history, personality, and forensic psychiatry, history of previous crimes or conflicts with the law. We have to see whether the particular crime about which the person has been sent for assessment, whether there is a motive or not, whether after the commission of the crime, there was a want of secrecy during the crime, want of preparedness. So if there is want of secrecy, want of preparedness, absence of motive, use of needless force, want of accomplices, generally a person with mental illness when commits the crime will be committed alone. Sometimes there may be multiple murders. There could be indifference to the crime committed. So these are the things usually are present if the crime has happened in the background of a mental illness. All of us have heard number of in the last few months. There are 2 or 3 cases of murders of the partner by the male partner were there, and if motive has been clearly established in those murders, so this means they try to keep it secret. there was preparedness, there was a motive. So number of things were there which say that the crime was committed. It was a crime not committed, not in the background of mental illness. No, expert evidence, no. Psychiatrist gives his or her opinion. That does not relieve the court from forming his independent opinion. The question of insanity finally is to be decided by the court, keeping in reference to the evidences concerned. We give the medical opinion, but the final decision is made by the court. There is another concept which is called partial insanity, where the understanding and memory are intact and dysfunction is basically in delusional area. This would be, we can say the cases of persistent delusional disorder, where the person's the cognition, memory, everything is intact. There is no disorganization. So they are the partial insanity. One example which Section 84 IPC gives: the accused kills another person who he thought was coming immediately to shoot him, and the accused acted in self-defense, thus not knowing what he was doing was wrong or contrary to the law. So this is a kind of example. Another example, this is more of a very simplistic term. The accused killed another person under a delusion that he was an earthen pot, say an earthen pot, thus not knowing what he was doing. Now, persons who have mental retardation with that would be moderate to severe retardation, or children below 7, they are generally not, they are not taken as criminally responsible, or children between 7 to 12 of immature understanding. So they can't be tried in the law. Now, what would be the steps in forensic psychiatric assessment? Again, to recapitulate, this is a standard psychiatric assessment: history, mental status. Sometimes we may need to admit the person as an inpatient for observation. One needs to go for repeated assessment. Generally, one assessment won't be sufficient for reaching an opinion. Investigations may be required, physical as well as the psychological investigation, psychodiagnostics, personality assessment. Now, in forensic psychiatric assessment, there are some practical issues, practical problems. Like, for example, a person may be sent for forensic psychiatric assessment after 2 years, after 6 months, 3 years of the commission of the crime. So there's a long difference in the duration between the time of crime and the time of assessment. Then you have conducted an assessment today, but the hearing may take place after 6 months or sometimes after 2 years. So these are the things that often a long time where, and by that time, the position, when you make an assessment and you go to the court for hearing, there's a long gap and the condition of the person may have completely changed. So, and one always needs to be on guard, because since falsification of information is not uncommon while doing assessment, so we need to be very careful about that. We need to be alert on the reliability of information which is elicited on history and examination. Many times you would get requests, your assessment, your opinion may, someone may try to influence you to make some different opinion. You may receive sometimes threats also. Sometimes there may be offers of favors by the family, by the antisocial elements, lawyers, persons in powerful positions. So these things are not uncommon. So we need to be careful about these things. We should not get influenced by these. Then there are motivational factors. Patient and family may not divulge full information and sometimes may even disguise. And sometimes no one is available to corroborate the information. So these are the many limitations of the forensic psychiatry assessment. Now coming to next step, that's the fitness to stand trial. How do we proceed for assessment? Reviewing the defendant's relevant medical records. So when the person comes, we request all medical records also. And sometimes the person may be on treatment out at our place itself, so you can have access to that record. All collateral sources of information like school records, academics, you try to interview family members if available. Chances are that they may not be available. One should always personally interview the person, defendant, person being sent. Detailed assessment, person's orientation, memory, concentration, mood. This is a standard part of diagnosis, psychiatric diagnosis. And then specific areas of competency to stand trial. I'll be discussing in the next slide. And report is sent, it's a written report with a well-reasoned opinion. How did you reach the opinion? And you have to address the specific questions asked by the court. I'll be discussing some of the examples, live examples in the later part. So once you are making an assessment, there's specific inquiries to be made. One is the person's ability to understand nature and objectives of the proceedings, charges which have been framed against the person, his or her role as defendant, how he would defend himself, how can he defend himself, how can he advise the lawyer, severity of the charge, what is the kind of allegation against the person, whether he or she is able to understand, pleas, how he can make pleas to defend himself, whether he's familiar with the courtroom procedure, who's a judge, there's a defense lawyer, there's a criminal lawyer, there is the opposite party, and the trial is adversarial, trial is likely to go against him, it's being done against him or her. His ability to assist in defense, cooperate with the defense lawyer, whether he understands the charges, his willingness to consider mental illness as defense, whether he is willing to consider mental illness as defense, his appraisal. Sometimes the person who is being sent for assessment, person has such a severe illness that person is not able to understand. So here the person would become unfit. Appraisal of evidence and likely outcome, appropriate courtroom procedures, rational account of defense, formulate defense plan, make reasonable defense. So these are many of these things are overlapping and not resorting to self-defeating behavior. Severe depression, person has guilt feelings or is already having suicidal ideation, death wishes, and may resort to sometimes self-defeating behavior. Now, another is that we often get cases of malingering. Court has suspicion that this person is malingering, and so how to differentiate between malingering and true mental illness? Again, the steps would be getting as much historical information as possible by in-depth interviewing, reviewing previous records, medical, psychiatric, educational. Maintain a genuine curiosity about the person, wide range of open questions to gather in-depth information, interviewing different sources of information, family members, previous healthcare services, different staff service providers, nurses, residents, security staff. We should try to get information from everywhere. Sometimes these days we have CCTV recordings also that can also be used. And when offenses are involved, police reports, witness statements, autopsy reports. So observation across time and situations during socializing, ward rounds. You're doing ward round and the patient is at a distance. So we keep an observation over the person. Daycare, when person is sent for assessment or for investigations, and interaction with the different other service providers like occupational therapists, probation staff, prison officers. We try to get information as far as we can get from different areas, and psychometric or personality assessment. And if malingerer has an existing psychiatric illness, that should be treated as per the standard guidelines. Now I'll be discussing some of the cases. Now this is a person was in around 40 when we saw him. He was accused of murder. This event happened in 1989. He was sent by the court for assessment in March 2000. Whether he's suffering from a mental illness and whether he is fit to stand trial. This patient had already been examined by different medical boards at the same place around 6 times, and despite that, the court had suspicion that this person maybe is probably malingering. We searched all the old records, And we found that he had been seen in a teaching hospital in 1987. We were able to get a prescription of 1987. Means the illness had existed before the event. There was a history of loss of sleep. Now, symptoms had been present since 1985, as per the version given by the patient's family members. There was a history of loss of sleep, wandering on terrace during night, saying that food smelled of meat, talking irrelevantly, suspiciousness, hearing voices. Now, these symptoms were also present when we assessed the patient in the hospital. He talked of many superpowers giving instructions to him, controlling him and the world by satellite. So apparently there were multiple delusions, there were hallucinations, olfactory, gustatory. There was also some level of disorder of thought, auditory hallucinations. So this was the background. Now, psychopathology has been consistent over previous 10 years, as was recorded in our hospital case files. We also did CT scans, psychodiagnostics, which favored schizophrenia. CT was normal. He had been admitted twice in our hospital. Otherwise, he was on regular treatment as outpatient. He was never able to give us details about his legal case. Observations did not reveal any inconsistency in the symptoms. The symptoms had been consistent over a period for many years. And there was a complete non-response to treatment. Even clozapine and ECT were not able to get response to the symptoms. So our report was, Mr. A was examined by the medical board at the hospital on these dates. He was also admitted for observation. He has, these are phenomena, delusions of persecution and grandeur and auditory hallucinations. Delusions are well systematized and consistent for up to 10 years. This was a period when we had assessed in our hospital, recorded in hospital case file at different times. He's suffering from paranoid schizophrenia. He is not able to understand the nature of offense he has been accused of and the court proceedings, and hence he is not fit to stand the trial of. So this is how we send the report of the person to the court. Now, this is another patient. This is again 38-year-old person who was charged of murder under section 3042, sent for assessment. Whether he's of unsound mind, these are the questions, whether he can understand the proceedings of the court. First contact with the person was in July 2000. He was seen by medical board on 9th August 2000, recommended hospitalization, was admitted around a month, was re-examined by the medical board, and then the final report was submitted. His only complaint was he was hearing barking dogs. No, he had been sent from the jail hospital, and this was the complaint, very simplistic complaint. In an old prescription of a general practitioner with diagnosis of schizophrenia, which also mentioned that the GP had referred him to NIMHANS. This prescription was of probably of Bangalore or Mysore. And examination, we also conducted the abbreviation using Entothal. We had a serial observation, psychodiagnostic, personality test, Rorschach. We could not get any significant psychopathology on assessment. There are more of I don't know responses. We also wrote to NIMHANS giving the dates that he was probably admitted during that period. And we got a response that he was admitted during this period at NIMHANS. A provisional diagnosis of schizophrenia was made, and history was just for 2 months at that time. And he had been seen only twice in follow-up. So after that, from 95 to 2000, there was no follow-up, no contact with any psychiatrist. So apparently he had improved from that, but he got that idea that he can use this pretext as for defense. So he was always emphatic that he had not committed any crime, was never able to tell how and why he reached the jail. He was able to give details of his earlier life in Mysore and Bangalore. Ward observation did not reveal any of it. So we gave a report. Mr. B had suffered from a psychotic disorder in the past in 1994-95. At present, he does not have any psychiatric illness needing treatment. He does not give any details about the criminal charges he has been accused of, or details regarding the defense, saying that he does not know. Objectively, there is no significant memory impairment because this we had tested on psychological assessment and clinically, and there is no evidence to suggest that he is not fit to stand trial. Now, this is a kind of double negative statement which is generally used in the when responding to the queries from the court. Now, this is another case. This was a young male, 22 years old. He was accused of sexual assault in 1995 and of murder in jail in 1996. Now, this murder happened in a cell in the jail in which there were 3 persons, and one was found dead, and the second, this person was just sitting across the dead body, and the third person was sleeping on the side, on one side in the that cell. He was sent for assessment in Feb 1997 from jail for whether he is suffering from mental disorder or not. If so, specify the nature of disorder and whether he is mentally sound to stand trial. First contact with him was in June 1995, before the commission of crime, when he had presented with a history of aimless wandering, violent behavior, disturbing neighbors, attacking members of opposite sex, and these symptoms are there for about 2 years. At that time, he was diagnosed as unspecified psychotic disorder and had been prescribed treatment. He had been arrested subsequently for crime of sexual assault. And in jail, he had been observed to be talking irrelevantly, smiling to self, and indulging in unprovoked aggression. He was twice admitted with us, once in February and March 1997, and then in continuity again for almost 5 months. So this was a long period because we are not able to reach a conclusion, and to break that malingering. It took us a long time. In the court, he had expressed inability to hear. In fact, there was an interesting incident. I had gone to the court for giving a testimony, and I told that he is not able to hear. And the judge, from a distance of almost 6-7 meters, and in the court noise, he called him and said, "Where is your father?" And he immediately responded. And the judge told me, "Doctor, you are saying that he is not able to hear. How he is able to hear in the court?" And in the court. So that was a kind of incident. Sometimes interesting incidents happen. ENT assessment had revealed neural hearing deficit. Vera had shown profound hearing loss in the right ear and mild loss in the left ear. So there was a partial impairment. He was provided with a hearing aid in the hospital, but he was often not using it. In hospital, he would often avoid questions related to illness and crime, but would respond to questions related to personal details, sometimes on oral and sometimes on written interviews. On 1 or 2 occasions, he gave rough details of the crime about the sexual assault and its consequences, but immediately avoided the further questioning. Means he was able to hear. Always use the pretext of hearing deficit to avoid questioning. So finally, we were able to crack this case that he is malingering, but it took us long time actually because he was also having psychotic disorder. So in that background, it was difficult to because it becomes difficult because he was on treatment and psychotics. So finally, then we gave the opinion that he's suffering from a psychotic disorder of unspecified type, from which he has improved with treatment and was declared fit to stand trial. This is another patient who had with the presented with the symptom of amnesia. This was a 22-year-old male, young male. He was accused of theft and double murder. He had entered with the intention of stealing in a house. There was an elderly couple, and they woke up, and he struck them with a stick, and both of them died. And he was arrested, and now he claimed loss of memory. Probably it was suggested to him by his defense lawyer that you feign to have a memory loss. And this event happened. He had been brought from Kathua. 600 kilometers from Delhi in the state of Jammu and Kashmir. Brought to hospital for assessment with a convoy of police. There was a truck, police truck from J&K, 6-7 persons who brought him here. And since the judge in the Jammu court had referred in fact, the person was referred to AIMS. AIMS did not have facility for admission, and AIMS referred to us. And at IBHAS, this was at the Institute of Human Behavior and Life Sciences, where I examined this patient. He was admitted under my care. We investigated, could not find any abnormality. And one day we had sent him for X-ray, and the X-ray room was adjacent to the ECT. And the police people who had come with him, they were always disturbed. They knew that he is malingering, but definitely, unless we have evidence, unless we do a proper, there's a report from a psychiatrist, you can't declare the person as having malingering. And when he was sent for X-ray, X-ray room was next to ECT. He thought that he will be given electric shock. And then he opened up out of fear that he was feigning memory loss on the advice of his lawyer. And we sent a report of being fit, that he does not have any illness, and he does not have any loss of memory. We sent the report. So this is how we are able to reach the conclusion. This is another patient, a person who was remained in media for a long time, for many years. This specific triple murder had made the national headlines in 1996-97. Attempts at his bail had failed. He was apparently advised by his lawyer to mimic mental illness. This case was going on for all this period, 96 to 2000. He was admitted under my care in 2000. We could not identify any abnormality. The second day of admission, he started accusing the clinical unit head, that was me, of being against him. On the third day of admission, he tried to assault me, the unit head, with an iron rod. And he also broke window glasses of the nursing station. Now, somehow I was able to understand that this trick has been suggested by his lawyer, that you do this thing and you'll be given some injections, especially antipsychotics, and the diagnosis of psychosis will be made, and then you'll be able to get that benefit. Somehow he was able to smell this trick. We did not show any reaction, and we discharged him, and immediately I phoned at the central jail that we have completed our assessment, and he may be called back. And so that's how we were able to. In fact, this was not the only interaction which I had with him. I had another interaction the day he was arrested in 1996, because I was going to Tihar jail, Central Jail, Tihar, on my weekly visits to see the patients admitted there in the psychiatric wards, and there I had happened to interact with him, and there he had presented with a depression. In fact, there was no depression, but he was so somehow there was a indirect kind of, had a longer awareness about his problems, his tricks. Now I'll be discussing, this is the slide is being repeated. Characteristics of crime in a mental disorder: absence of motive, no attempt of concealment of crime, absence of accomplices. Now, this person who was accused of triple murder, he had employed some professional criminals to in that specific murder, in which he had murdered his one doctor and his two employees. Impulsivity in crime, victims are often near and dear ones, brutality of crime, complete emotional indifference, amnesia for the crime may be present, past history of mental illness. So these are some of the issues which are seen in the crime, which is due to mental illness. Now coming to a slightly different area, appointment of guardian and manager for the mentally ill. When a medical practitioner is called upon to give his opinion after examination of a mentally ill person in such cases, we should not, it's not that we have to just say that this person is mentally ill, but we have to certify that mental illness is of such a degree so as to render him incapable of taking care of self and manage his or her property. One must be careful while giving this opinion because a person may be mentally ill but is capable of taking care of self and property. So just having illness, schizophrenia, does not mean that person is not capable of taking care of self and property. So this all needs to be assessed. Assessment is made about the extent of lacking sufficient understanding or capacity to make or communicate reasonable decisions or taking care of self. Now, in case of doubt, opinion should be given towards sanity rather than insanity. Now, this is a case of 56-year-old unmarried lady who was brought by her elder brother on a court order for examination by a panel of doctors to determine whether she is capable of taking care of her person and manage her property. Court had specified a date. By this date, the report should be submitted. We saw in the walk-in clinic, we did IQ because it was appearing that she was having some intelligence. We then did the detailed workup on the same day and was seen by the medical board on after about 2 weeks. The court had asked for the report by this date, but since it's not possible generally to conduct a detailed assessment in such a short time, so you need to inform the court that the assessment may require more time. So that kind of intimation needs to go to the court. She had been symptomatic since early childhood. Symptoms were characterized by low intelligence, inability to take care of self, unclear speech, inability to remember even names of immediate family members. There had been history of 2 generalized seizures around about 1 month prior to assessment, for which treatment had been started. Elder brother had been supporting her since the death of parents. IQ revealed mental age of 3 years on Gestalt on GDT, 3 years on social age on VSMS. Social quotient was 20. CT also was done, and there was brain atrophy with hydrocephalus. So we gave an report that she is not capable of taking care of her person and manage her property. Now coming to another area which we psychiatrists may be asked to assess. This is the child custody and adoption. Generally, it's presumed that the welfare of the child of tender years is best served by the maternal custody. When the mother is a good and fit parent. But we need to consider conflicts between parents or between parents and grandparents or natural and adopting parents regarding the custody of the child, because sometimes the parents are maybe the adopting parents. Permission needs to be given to the divorced father to visit the child with maternal custody. If mother is mentally ill, we need to have a safer placement of the child, which could be with father. Same way, suitability of child for adoption is to be considered. Then the emotional stability of the couple for adoption. So these are the different things which we need to consider. The Hindu Adoptions and Maintenance Act 1956 has given some guidelines about the adoption by a Hindu male who is of sound mind and is not a minor can adopt a child, provided that he has a wife. If he has a wife living, it can be done only with the consent of the wife. Any female Hindu having a sound child, having a sound mind, and who is a major is eligible for adopting a child. If she is married, then consent of the husband is required. Now, another area where this is now we are coming into the civil responsibilities or cases of civil cases. testamentary capacity. A request may come from self. Sometimes the person himself herself may give a request for testamentary capacity, that he is capable to make a will, or it may come from family or from the court. Detailed psychiatric assessment, especially the cognitive functions, need to be done. Now here we have to assess whether subject is aware of its nature and extent of his property, fact that he is making a will, and identities of his natural beneficiaries, who could be spouse, who could be children, and other relatives. The status, mental status at the time of writing the will should be stated in that. Sometimes it's possible that person may be suffering from mental illness, but that does not make a person incapable of losing the testamentary capacity. Another area where assessment may be asked for is the divorce on ground of mental illness. According to different marriage acts, including Hindu Marriage Act, Parsi Marriage Act, and Christian Marriage Act, divorce can be granted if one of the parties is of unsound mind, of incurable nature. Now, it's a clause is incurable nature, or suffering continuous or intermittently from mental disorder of such a severity that petitioner can't reasonably be expected to live with him. The person is not able to meet the marriage responsibilities. Now, as per Muslim Marriage Act, a Muslim woman can seek divorce on ground that her husband has been insane for a period of 2 years. Again, the insanity would have the same criteria. Indian Divorce Act for Christians concerned in mind this ground for divorce in 2 conditions. It must be incurable, it must be at least for 2 years immediately before filing the petition. So incurable means that person is not able to, not in a position to live a married life, or say carry out the responsibility related to marriage. One of the related cases related to divorce on ground of mental illness. This lady, 28 years old, had attended in assessment our OPD in May 2009. Reason for assessment was husband was seeking divorce through court, stating the wife to be suffering from a psychiatric illness. She had been married in Feb 2007, that is 2 years prior to this prior to the time of assessment. There had been marital discord over trivial issues. After altercation with her, the husband asked her to leave the house as she was not liked by her in-laws anymore. She had delivered a baby boy at her parental home. She returned back to in-laws in a few months, but the marital discord continued. Husband had filed a case in the court seeking divorce on ground of mental illness. Some issues had been resolved after the court's intervention, and then she had been sent for psychiatric assessment. Psychiatric assessment did not reveal any active psychopathology. There was no evidence of psychiatric illness. Psychological testing showed normal intellectual ability, some level of immaturity, dependency, anxiety, and affection needs. There was stress in the areas of interpersonal relations. Overall, it was an integrated individual, and there was no evidence of psychiatric illness. And we sent a report that she does not have any psychiatric illness. This is another case where a mentally retarded husband was exploited by the wife. The person had been sent for psychiatric assessment. Reason for assessment course about his incapability of looking after his interests. Assessment was had shown moderate mental retardation, though he had behaved appropriately in social situations, interacted with his siblings. What had happened was wife had taken his thumb impression on the property documents and sold his land without consulting the family members and informing the patient. So IQ on assessment was in the range of 47 to 50. We made a diagnosis of moderate mental retardation and informed the court about it. Now, what happens is in most of psychiatric assessments, we are able to give the report to the assessment, to the courts, but we are often not aware what happened afterwards. Because the cases often continue to pull on in the courts, and the judgment may be given after a few months and sometimes after years of submission of the report. So psychiatrist often is not aware of the final judgment. So our report has stated he has moderate mental retardation, is not able to look after his interests, manage his property, but is able to take care of personal relations to some extent. So ability to take care of self, but not ability to take care of his properties. Now I'll be discussing more cases, and then we'll conclude. These cases were in media, national media, in fact, also TV channels for a number of weeks in 2006, starting December 2006, and these cases went on for a long time. A series of murders had taken place, murders for the young girls had taken place in the Nithari. Nithari is a small urbanized village in Noida, residential industrial township. Number of girls had gone reportedly missing in 2005 and 6 from the village. Now, 2 residents suspected one person who was a domestic help in a house in Noida to be involved in these disappearances. The suspicion had come from finding of human body parts by some of the residents in the drain of the municipal water tank located behind a specific house. Further research by the police on this complaint found number of body parts in the nearby areas and also decomposed bodies. Now, in this house, only 2 persons used to live, the owner and the domestic help, and the 2 were taken into custody for investigation by the local police. This case was given to Central Bureau of Investigation, that is CBI. In fact, when I was searching recently for making preparation for this presentation, there's so much of information available on Wikipedia. In fact, there have been 2-3 films which have been feature films which have been made on this incident. Now, most of the missing persons included young adolescent girls or young women. There also a boy. The 2 suspects were taken in custody, and we came into scene when they were requested. The Department of Forensic Medicine at AIIMS requested the Department of Psychiatry for a mental health assessment of these 2 suspects. A medical board was made. Me, another 2 faculty colleagues, one from clinical psychology and one from psychiatry. Now, we could not have admitted these 2 suspects because there was a lot of public unrest against these people. They could not be considered, their movement was not considered safe, and they were under CBI. And so we said that we can go for serial assessments of these 2 persons. And they would be brought to the hospital with the covered faces, and in a specific room, we would be conducting the assessment. Now, this domestic help. He was 31 years old, married male, educated up to primary level, domestic servant, was in present job since January 2004. His wife and children were in a native place, 500 kilometers above. Whenever his employer would go out, he was asked to sleep in the drawing room of the house. And otherwise, he would sleep in the servant room. While sleeping in the drawing room, he reported hearing sounds of some dogs barking. Sometimes he would claim seeing a figure in white suit with long hair standing near him and laughing. He could see only her back and never saw her front. So a kind of pseudo hallucination we can, from psychiatric assessment, we can interpret. And such experiences never happened during daytime or while he was sleeping in his own room. And he said that it was very distressing. Once or twice he had seen such a figure near a tap on the backside of home. He had informed his employer about seeing this figure. His employer had reassured him that there was nothing like that. There was history of masturbation since 14, 15 years of age. He continued to masturbate even after marriage. He had some problems regarding sexual performance. There's no history of having sex with children in the past or with the animals. He would get thoughts of killing and eating someone, cutting and eating someone. One day he called a young girl of 13, 14 years of age to his drawing room around 10 to 11 a.m. when his employer was not in house. He was not able to recall the events afterwards till about 4 p.m. No, I'm saying that he was involved, accused of number of murders, but this specific event he narrated to us. And he said that about 4 p.m. he saw the girl lying dead with a scarf tied around her neck. He then realized that he might have killed her by strangulating and might also have had sex with the body. He then became anxious. Her shoes were in the bathroom. He cut her body into pieces and also ate her flesh, filled the body parts in small polythene bags. So this is one event he described to us in one of the assessments. In the same way, he might have killed many girls and 2 boys. He did not know most of them except 2. And so this is how the things went on. He had killed number of ladies, number of that he was accused of. So there are a number of cases against him, and now our interpretation. He was aware of the criminal charges he was being investigated. State of mind at the time of commission of crime is difficult to comment. As the subject said, he was not able to remember his state of mind at the time. He had committed the criminal acts of murder and he had sexual intercourse with the bodies. It appears that he was emotionally charged at that time, but he was anxious while he was disposing the body parts of the child and ladies he had allegedly killed. He also used to feel afraid that somebody might see him while showing the body parts and then he would be in trouble. He also never bothered about consequences of his actions. An impression could be drawn that he was fully conscious at the time of alleged commission of crime and was also aware of consequences of act. Possible consequences proved guilty. He expressed ignorance but was aware that he had done a serious crime. About his understanding of legal proceedings and ability to defend himself, he said he did not know. Investigations did not reveal any significant abnormality. He also went for MRI, EEG, psychological testing. We gave a report that he's suffering from necrophagia. He does not suffer from any psychotic disorder or any other psychiatric illness except for necrophagia, a type of paraphilia, sexual perversion disorder. He was fully conscious at the time of the alleged commission of crime and also aware of the consequences of the act. There is nothing to suggest that from assessment, that he is not fit to stand trial. This is the owner of the house, 49 years old, flamboyant kind of person, married, businessman. He had lost mother at the age of 7 to 8. There was history of use of alcohol since 15. He had lost his father 8-9 months ago. He felt depressed and reported ideas of hopelessness as he was also beaten up by jail inmates on the day of his arrest and later by the lawyers. Regarding the events leading to his arrest, he informed that he had felt smell because of a big drain in front of his house and had inquired about it from his servant, who told him that the neighbors had thrown garbage. In one specific incident, when this murder happened, in January 2005, he and his wife had gone to Australia. And he said when he came back, he did not observe any change in his subject's behavior. This is probably the time when the first event happened. About awareness about the crimes he had been accused of, he had been interrogated about his knowledge of alleged criminal activities of his servant and murder. of the daily state of mind at the time of commission crime. This was not applicable. Possible consequences proved guilty. He reported that it could be quite harsh. Understanding about legal proceedings, he said that he would justify his innocence. Psychological testing showed anxiety, depression, sexual conflicts, internalization of aggression. There's no evidence of any psychiatric or emotional disturbance. So we gave the report that Mr. F suffered from alcohol use disorder. He did not suffer from any psychotic disorder or psychiatric illness. He was aware of criminal charges he had been investigated for, and there was nothing to suggest that he was not fit to stand trial. Now, some of the things, cautions we need to use when we are called as expert witness. Listen, we should listen closely to the questions being asked by the court. We should stop talking the moment the judge begins to speak. This is a court decorum. We should remember the limit of our field. We should avoid the terms like always and never. Because psychiatry is not a very definite definite science. There are always maybe, things may not be are there. If pressed to answer in yes or no to a complex question, we can say question cannot be answered in yes or no. We can explain further. Should not be reluctant in saying that if it is true, I don't know. Speak simply, simple, use simple words, avoid jargon, and be tactful. These are the common questions one may be asked when you appear in the court. What is the psychiatric diagnosis? What are the findings? Is the accused sane? What is the intelligence level of accused? Is the accused an alcoholic? Was the accused drunk when the crime was committed? Is the accused addicted to some drugs? Did the accused know the nature of the charge? Did he know what he did was contrary to the law? Does he understand the seriousness of predicament? Is he or she capable of cooperating in defense? Is he or she capable of forming the degree of intent, willfulness, or premeditation? Was he or she in grip of some irresistible impulse? If yes, whether it's psychosis, neurosis. If amnesia is alleged is caused, what could be the cause? Prognosis in terms of treatability. So there are a number of challenges in conducting psychiatric assessment. There are concerns about the consent, as I said in the beginning of my presentation. Ascertaining that information being given is correct. Person being examined may give conflicting information to the doctor. There could be conflicting versions from different sources of information. Then there's an ethical dilemma of psychiatrists that his opinion may go against the person if the person is having mental illness. The final report needs to include identification details, name, age, gender, father's name, reason and source of referral, assessments, dates of assessment, responses to the question. If a person requires treatment, it should be treated, it should be mentioned clearly. One should always be relevant, specific in the reports, and avoid technical terms. To conclude, I would say the expert opinion does not relieve the court from forming an independent opinion. Medical opinion helps the court in reaching a judgment. Sometimes it may not be possible to provide answers to all the queries from the courts. In such cases, reason may be communicated like there are limitations of science or limited sources of information. With this, I conclude. These are some of the references. In fact, there is a very good book by Dr. Jilova and his colleagues on forensic psychiatry in Indian perspective, published by JP. Then there is a NIMHAS publication which is available as free to access. Then there is a book by Fundamentals Forensic Psychiatry. This is by B.K. Puri. And there's a APA American Publishing House Principles and Practice of Forensic Psychiatry. Thank you.
There's one question in the chat.
Yeah. Any generic format for fitness to stand trial for psychiatrist? See, there are a number of scales or assessment procedures which are available in the text format. In the some of these are in the textbooks which I have mentioned, but a simple format which I have given 5-6 steps that making a general assessment, psychiatric assessment, and whether the person is able to understand the court procedures, the crime he has been accused of, how he can make defense. So this is a standard format we can use, and otherwise we can go for much detail. There are a number of detailed formats which are available, but that make it more complicated. It's better to remain simple. But one can easily refer to the these 2 articles which I have quoted there in my slides, and also can refer to those textbooks. There's another, how to deal with episodic illness such as rapid cycling bipolar with psychotic illness if backdate assessment about the insanity is asked by the court of law. We try to get generally the person when the person is sent for assessment, the event might have taken few months or sometimes even few years ago. So we try to get if there are any case records available during of that period, whether the person was on treatment, whether he had consulted during that period with a psychiatrist, and those treatment records are available. If those are available, you can make an opinion. Otherwise, we have to mention that it's difficult to comment what was the mental state of the person at the time of commission of the crime. So it depends on how much information we have available for that. Like in the case which I referred, the murder had taken place in 1989, but unfortunately we were able to get a prescription of 1987, so that we were able to make an opinion that illness had existed before that. But again, at the time of crime, you are not able to. Sometimes it's not easy to make a conclusion unless we get full detailed information. There are witnesses who have observed the person at that time. So if we have access to that information, you are able to give that kind of opinion. What was the condition? What was status at the time of commission of crime? Dr. Gurinder Pal Singh has asked about capacity assessment and its applicability. Capacity assessment would depend on the specific area, because that would differ from, like, it's a capacity to make will, whether it's capacity to give consent for admission or capacity to give consent for starting treatment, or so it depends on the which area we are assessing that capacity, and accordingly one has to make judgment for specific area. If there are any more questions, you can say. I remember as a senior resident going to a court in Himachal Pradesh at Una. This was a young boy, he was around 15, 16. And he had been on treatment for epilepsy for some time, and he had killed his uncle and grandfather by shooting. There was a pistol lying at home, and he just took out the pistol and shot his uncle and grandfather dead. So that was a kind of, probably it was a part of epileptic phenomena or some kind of automatism kind of, and Caesar was in partial control, because sometimes no, you can't understand that there was whether it was in a fit state of mind to. So that was the situation. Sometimes you have such incidents also where you definitely you can say that that is what not. Because it happened in the background of mental illness and in the background of this crime was happened in the background of mental illness, or it was a definitely organic illness, that epilepsy and so he was not aware what he has done at that time. It's only after the event happened that he got to know. And recently, this court is still under this case is still under investigation. This girl has been charged of murder. He said the crime is that she has been accused of killing his brother as well as mother. This young girl of 15 or 16 and studying in 10th, 11th standard. She has been a professional shooter, had been participating in the shooting contests, and one day in the morning, probably they had celebrated a birthday also, something of brother or father, and then he shoots shots dead her brother as well as the mother. That case is still under investigation. Had been seen by me, I think, 2 or 3 occasions. We have another questions. Is there any specific situation where assessment? This question is from Dr. Ravikant Kumar. Is there any specific situation where assessment can be done by private practitioner or can be done in government setting itself only? It depends on the court. Sometimes the psychiatrist, if psychiatrist is government facility is not available, but the opinion can be taken from the private psychiatrist. Sometimes even second opinion, like this incident of Himachal, in which I had gone appeared. I think after around 15 years of that, my appearance, I happened to meet a psychiatrist in Himachal, and we were just discussing about the court appearances, and then he shared that he had appeared for this specific case for which I had appeared as senior resident. So sometimes a private psychiatrist may also be requested for opinion. Assessment of fit to stand trial if inmate is aware of charges. Assessment of fit to stand trial if inmate is aware of charges, aware of consequences, but not willing to defend. Yeah, interesting question. I think I also dealt with this thing. But if see, we are not making any, we are being asked by the court to make a assessment. A person say that he is not willing to defend, but definitely he is not fit to stand trial. So, because he said that I don't want to defend, this means this will go against the ethically, it will go against law that if we say that he is fit to stand trial and he's not willing to defend. No, that's his right. That he has mental illness, so he should get the benefit of mental illness. And only when he recovers from mental illness, only then he should be. It should be communicated to the court that at present he is not willing to. He is not fit to stand trial, and this specific statement can be done that he has stated that he is not willing to defend. Will high level of impulsivity can be found to escape from charges? No. Because impulsivity, like emotionally unstable mental disorder, or borderline personality disorder, or antisocial personality disorder, who has done a crime under impulsivity, for a person who is alcohol dependent and he under influence of alcohol does a crime, so that does not absolve him or her from the crime or does not make it as a defense. This question from Dr. Preeti. If a court has asked only for assessment, can we also treat the patient if found to have mental illness? We should only do assessment and communicate to the court that there is need for treatment. I think we need to mention, because this person is generally under the custody. Person is in the jail, so we would need to inform the court that this person has a illness which needs treatment, and so he should be referred to the relevant doctors. We can't do this treatment, can't prescribe treatment from our side. We have to inform the court. If a patient asks certification of mental illness to produce in police station to protect himself, are we obliged to provide? When to decide to form a medical board? Only when there is a request from the court. Yes, this is this should not be done on the request from the person, because we don't know the intent. That is one, and there's no point in indulging yourself in problems. And a certification of mental illness to be provided to police station, that is, there's a straight no. Even for certification to be provided to the court on the request of the person, we should not be taking law in our hand. Unless we are asked by the court, only then we should be, because medical legal assessment is a very specific assessment. So we need to be taken only on request from the court. So, Preeti, if there are no questions, we can close down.
Thanks, sir. So would you like to ask any questions to the participants for assessing them?
No, I have not made any. There's one more question. You have mentioned a request for assessment can be done on personal request, as in case of testamentary capacity. Yes, testamentary capacity is a different thing. So there we definitely that can be done on personal request, but not for others. For others, it has to come from the authorities. Like for example, in case of fitness for a job, it has to come from the employer. In case of adoption, it has to come from the adoption agency. Adoption agency means like there is a government adoption agency who will be deciding about whether person is fit to be given adoption. So there we have to go for it. Current status of IPC 309, it still stands, but we can take the help of our Mental Health Care Act. We say the person has suicidal ideation or suicidal risk, or the person should be treated for under the Mental Health Care Act.
There are no more questions.
So, can request Dr. Sood to.
Okay. Thank you, sir, for such an informative talk. I would now like to request Professor Ajay Kumar Sood, sir, the Deputy Secretary of National Academy of Medical Sciences, to deliver the vote of thanks.
On behalf of the National Academy of Medical Sciences, we are really very grateful to Professor Rakesh Chadha, sir, for making this very complex and difficult and challenging topic of forensic psychiatry in a very simple way, giving the cases and giving the practical tips for our students as well as other participants when they are appearing in the court. Thank you so much, sir. A very interesting session, and I'm sure that our participants and PG students have definitely benefited out of it.
Thank you.
So again, sir, on behalf of NAMS, we are really grateful to you for being the chief coordinator for the series on psychiatry session. And all these sessions have been very, very, very useful and very much liked by our participants. So thank you so much for your support to the guide. We are grateful. Thank you, sir. We are grateful to Dr. Preeti for moderating this session and always helping us as a moderator for these sessions. Thank you so much. In the end, I would like to place on record the support which we have been getting from our IT team, Mr. Ravi and Mr. Anil. And again, for the participant, I would like to remind them that next week, that is on next Thursday on 29th, we have another very interesting session that is again a very important topic in psychiatry, that is substance abuse use disorder. So please attend that session. And with that, we will conclude the series on the psychiatry. And another interesting session, which is due on Tuesday, that is on 29th, is related, 27th, that is on diabetes by Dr. V. Mohan, and where he's going to discuss the differential diagnosis of diabetes in the young. So please, these are the two sessions which are due in the month of June. So please ask your colleagues and attend this session. In case you have any suggestions regarding the next series of sessions, which we are going to start in July perhaps, or maybe the beginning of the August, please give your feedback on the themes, on the topic which you want us, and again suggest what timing and days of the week are suitable. So with these words, once again, I thank you all for being with us this evening. And once again, thanks to Professor Chadha and Dr. Preeti for making this session so interactive and interesting for all of us. Good evening and thank you very much. Over to you, Dr. Preeti.
Thank you. I declare today's academic session closed.